Hi, everybody. I'm Aditya, and welcome to Digital Health on Air. I'm joined by Kathleen Snyder, who is a health IT policy and interop expert and a senior counsel specializing in healthcare policy and regulation at Hutch Blackwell. We're so excited, Kathleen, to have you with us today, kicking off 2025, and we're going to look deep at the current state of interoperability. Kathleen, welcome.
Thanks, Aditya. I'm super excited to be here.
So I'd love to kind of get us started, learn a little bit more about your work for our audience. Tell us a little bit more about kind of the work that you do.
Sure. So I have an unusual background where I really have that technology healthcare intersection, and that is where my laser focus tends to be. So I run the gamut of healthcare policy, as you mentioned, to helping folks do their commercial contracts and all of the in between. I like to think that some of my value add comes from the fact that I know all of these things and then can help hone down. I was recently referred to as a Swiss Army knife. I sometimes prefer utility player, but it's all good.
I think that's fantastic. I mean, and we've had an opportunity to work together for quite a number of years in the past. And I think one thing that's always impressed me and why we wanted to have you on Digital Health on Air is really because there's the practice and then the reality. There's the law and the reality, right? And how these things interplay, especially in the world of healthcare IT, is really sophisticated, complicated, and we rely on experts like you. So let's take a look at 2024. Can you kind of take us on maybe a journey, a story? You've been through a lot of healthcare IT, a lot of healthcare interop work that you did with HIEs in Massachusetts, I know from your background. Take us a little bit through about data interoperability, where we started, how we got to where we are, and how we got to this moment in time.
Oh boy, how much time do we have? So do we go back to the initial executive order and then fast forward to high tech, and then we can zoom through some, late teens, I think.
I mean, I think 30,000 pages in rulemaking in about 3 minutes. Go.
Whew. Okay. So fire is good. Things are on fire. And where can we start? There's been a lot of change and a lot of formalization. I think the last 4 years, the now newly named, let's see if it rolls off the tongue, ASTP/ONC.
Yeah, that's a bit of a mouthful for me too.
But they've done a great job at really expanding the footprint to say, we're not just this weird standalone agency that no one pays attention to. We are the underpinnings for all of our sister HHS agencies because it's 2025. We need to get digital in terms of our healthcare. We need to get it right, and people need to get on board with interoperability and seeing how AI comes into play. And if the foundation is not there, it's going to be really hard to have our AI chatbots reading paper charts. So it's time, folks. It's time to come on.
Yeah, and looking back at 24, there's a lot of kind of motion around the ONC published a 5-year roadmap. There was HTI 1 and 2 and 3, US CDI V5 and 6. What was something maybe memorable to you in 2024 that happened in the world of interop?
So I was really impressed with HTI 1. I thought that it was a really brave move on ONC's part to take the first step in the federal government towards saying, hey, healthcare AI is here. How are we going to think through it? And what are we going to do in this space? In addition to all the, very, very nitty gritty detail that they added into the regulations. And it just, but I really think that the faves just set the stage for hey, we're thinking about this.
Right.
And other people should be thinking about it as well.
So for kind of the people who aren't so masters of the dark arts of interop, if you will, walk us back a little bit. Tell us HTI 1 and kind of, the subsequent stuff. What is it? Let's maybe start with simple. What does HTI stand for? And kind of
that's a difficult question.
I know. I was actually thinking, honestly, Kathleen, as I asked the question, I'm not even sure I know what it stands for.
There's so many acronyms in this world that you just blend them in.
Oh, I know.
They're even faves, which, I fairly, I reference on a rate. Okay. Fair, appropriate, valid, effective, and safe.
And the other one.
And the other one. So I'm going to punt back to you on the actual HTI.
That's fine. I can do a quick Google while we're talking.
Yeah, you're a better Googler online than I am. So, you have 1, you have 2, and you have 3. And so there was a big proposed to, that was then kind of, so right before the holidays, right before the end of the year, we had HTI to the final rule, which was primarily focused on TEFCA. And that is an area for someone who is a geek about interoperability, is a sort of a blind spot in my world where, over the past 5 or 6 years, I haven't had a lot to do in the TEFCA world.
Sure.
I've focused more working with people like Luma, or companies, I guess, like Luma, that are really looking to understand the interoperability, from a very practical, like, we want to connect, we want to do business, we want to bring all of these disparate folks together and help make healthcare better and easier and simpler and better for the patient, better for the providers. And so TEFCA has been a little bit of a side, but that was HTI 2, the final rule was primarily there. And then HTI 3, the really kind of interesting pieces about it were with regard to the healthcare, reproductive health, and the exceptions to the information blocking. That was my high level takeaway. When I looked at them, I'm like, really? Did these guys, did they prepare for the holidays? Did they have holidays? Last year they reached, they released HTI 1 right after. I was like, what? Did they get holidays? But
the amount of paper that slams like towards the end of the year is always just a little bit like, oh, and here we go again. So you said something in there which is really interesting. I think in 2024, it's a topic that you and I have tracked for quite some time, which was information blocking. And there's a lot more, you'll tell our audience, like, enforcement's not really the right word, but like, a lot more formalization around the process around information blocking. So like in their last kind of, we'll wrap up in about 2024 in a second here, but I think it's a topic that a lot of folks in the health IT world are very passionate about. So why don't you just catch everyone up on kind of like the progress that was made around operationalizing, if I think that might be the right way of saying it, what happened with information blocking?
Sure. So I think it went from, kind of very high level, like, you guys, we need to move forward. We need to think about this. We need to work. There's going to be the naughty list for people who aren't complying, but no one's really nothing's going to happen there.
Right.
We did have the OIG come out with, final regs on how they're going to enforce it. And then we're, kind of moving towards more formalization. The exceptions have been honed a little bit more. They're still generally the way they were, but I think they're trying to plug up some of the holes that people were trying to drive their Mack trucks through. And, from my perspective, I think that people are doing better. You tell me. It's, I think that you're probably finding that people are a little bit more cooperative in the space than perhaps they had been.
I think from my perspective, kind of especially as a vendor, kind of to use that terminology in the healthcare IT ecosystem, there's a lot more information available just kind of publicly about connectivity with EHRs, connectivity with data sources, systems of record. Compared to when we started Luma in 2010 or 2015, I should say, that's markedly different. So like positive, right? Whether it's like exactly as the government had hoped for it to happen, always kind of hard to tell. But like you can definitely sense that like the boat is sort of moving in a different direction now. So I think kudos to those activities there.
Yeah, no, I agree. And I think people are more aware, from a patient perspective. It's like, hey, I have the right to access this. Let me access it. Or why are you making me print out or carry my images on a CD?
I was going to say, someone's going to say CD-ROM. It's just
CD. It's right there. I'm exactly. A throwback. But it's better than the facts where, we definitely still see clients in healthcare. So now in my current role, I represent both, companies like yours, smaller, innovative health tech companies, but I also am working with larger healthcare players. And the fax machine is still a real part of the day-to-day business ops.
Honestly, in my personal care, I've tried to get a referral to a specialist in the last couple of days, and they said, "Oh, can you send us the lab results?" Can I send the lab results over via fax? I'm like,
No.
Here's my fax machine that I happen to keep around in this paperless office. So, I mean, it's alive and well, right? And I think that's one of the things. Maybe that helps us turn the future, a look towards 25 and 26, kind of looking ahead a little bit. You know, there's a lot of change, obviously, both from the regulatory perspective and all that sort of good stuff. But, you know, the overarching thing, like overarching desires to allow patient, I think, to access their own data and kind of allowing interop, like that's sort of, I think that's water in the bridge now. That is just kind of in the current of healthcare at this point. So kind of where do you see things going? Like, you know, HCI3 dropping, like all these different pieces, US CDI, B6, like and crystal balls are just that. They're just crystal balls and they're murky as all get out. But what do you see happening?
Yeah, it's a great question. A couple of months ago, I was at an interoperability, kind of get together in the Boston area as one does, and Jonathan Bush was there, kind of the OG of interoperability. And he's like, it's just going to keep going. We spent so much time, putting it all together. And I think that there's enough gravitational pull from the industry and from folks who care about the space to have it keep progressing, to keep moving forward, because it needs to move forward to help healthcare get better.
Yes. So, I agree. I mean, I think we've all had, as a patient, I don't think you realize how what you say is as a patient experiences frustration, oftentimes maybe under the hood is an interop gap, right? Yes. It's like, it's hard to schedule. I don't know how to get that appointment. That referral requires me to fax over. And that is going to, you see that as a frustration, but under the hood is actually a bunch of regulatory, technological, other pieces that have gaps that I think I think to that point that you're saying that Jonathan Bush is saying, for those who don't know, he's one of the founders of Athena, or the CEO, I think. I'm not sure if he's the founder.
Now he's Zeus Health.
There you go. And I think the flywheels happen, and that's good, right? That's good. It's better for health equity. It's better for health outcomes. It's, if anything, it's better to make patients less annoyed at healthcare. So.
Well, to some extent, I also, maybe I'm taking this in a little bit of a turn, but I think that it's good for patients, and it's been a pain for providers, right? The faxing and the information. And I'm not going to go out on a limb and say it's not still a pain for providers, but I think that some of the technology is trying to help streamline and smooth out. So some of those bumps and that friction on the provider side as well is, kind of smooth.
Well, let me maybe ask you the question in this way. I normally focus on how to make the patient's experience better, but you're bringing up an interesting point around the provider's experience. In your kind of vantage point, do you feel that providers have a hidden cost to providing service because of a lack of interoperability, i.e. they pay for it with human capital?
Yeah, I mean, the number of people that, provider office has to staff to run, an office and either answer the phones or get the faxes to the right places and, then scan the PDFs into or append them to their EHR systems. It's a lot of work, from a bureaucratic,
just paper pushing, right?
Paper or virtual paper at this point, which makes it sometimes even harder, because then you have that red folder that's really important, but it's buried at the bottom of your chart, but it's in Epic or somewhere else, and you don't actually know where it is. So I think, yes, I think it's been really difficult for the providers as well.
Let's maybe dig in a little deeper into kind of the financial effects and how that kind of impacts the various industry stakeholders. We often talk patient, provider, and payer. We kind of, there is a whole, I think, part of the story, which I don't spend a ton of time thinking about, which is the payer side of the equation. Getting records, understanding longitudinal care. Patients change payers, on average, every 30 months or something like that. So that's very fast. So talk to me kind of what you've seen from your industry experience and how those financial impacts get boat drags without interoperability on various.
So I think it's hard, and I'll pivot a tiny bit, but I think that there's a real opportunity here for innovative companies to come in and say, okay, let's figure out how to help you manage your workflow or your processes and, streamline a little bit. And you can do that because interoperability is starting to really take hold, but then you layer on, AI and, sometimes people are like, oh, that's a bad thing. And I know that there's some concern about the use of AI, which I think is valid.
Yeah, sure.
Even in sort of more bureaucratic or
Operational kind of
operational
scenarios.
areas, because no one's paying attention to it, right? So you're not paying attention, like, were you taking the facts from Kathleen's chart and appending it to Aditya's chart, or is it, because if there's not some sort of checking, that could go haywire pretty quickly.
Yeah.
But I do think that there is some real opportunity here for getting rid of some of the bureaucratic nothing crazy, but saying, hey, Kathleen needs a referral or a prior auth, and all of this information is in her chart. Can we just populate it?
Extract the relevant bits.
Exactly.
One of the hardest parts I've heard from folks, and I've spent some time kind of digging into TEFCA and kind of, talking to providers who are adopting TEFCA-based data exchanges. And, one of the hardest parts for them is exactly that, which is I get a chart from, when the patient went to the ED or whatever it is, and I get reams and reams and reams of data. I'm like, I don't know how this is relevant to their foot sprain, right? And just like kind of understanding that, I think that's an interesting part. And I want to ask you a little bit more, since you took us there, and I think it's really relevant, is how does AI start to change how we think about interop? Do we feed there's so many ways one could unpack that question. I'm asking a very loaded question. But I'm sure you've got this from your clients and people have had asked for your opinions on it. So I'm just going to follow this.
All right. Well, and these are my opinions, not necessarily shared by anyone else. I think that there's a lot of tremendous value, right? And I think as we hone in on a standard, right? The US CDI, it's like, okay, these are critical things that everyone needs to know about me when I go from provider to provider, or if I show up in the emergency room and no one knows who I am, they can figure it out. And I think that there's a lot there, but I think standardizing some of the prior authorization requirements, amongst payers, and standardizing them and saying, okay, this is the data that we need to see.
Right.
And we need to see it, and this is how we need to see it, and this is what we want you to provide to us. And let's put aside the whether or not an algorithm is denying the care. That's a whole different story. I don't appreciate it. And I don't, I have my freshman in high school as a swimmer, and he needed PT, and it was just denied. I'm like, why was it denied? There's a referral, But anyway, so PT.
This is what I'm saying. All of us have lived experiences.
Oh yeah.
Almost certainly. I'm going to guess without needing to say anything more. It's there's some piece of data that didn't land from point A to point C, right?
Probably. And the amount of time it tries to take, it's like, okay, I'll just pay the PT directly, and I'll
deal with it later.
Calling later, and when I have 3 hours of free time to sit on hold, then talk to the chat bot and say, please, can you just tell me what I need to submit? And you understand why people are frustrated.
Oh yeah.
And we're in this space. We
and we're experts but practitioners of the systems that make this happen. Yeah. I'm curious to get your take, because the story of your son and the PT is actually really illustrative for me, at least, on do you believe, in your opinion, that US CDI and the regulatory set needs to expand beyond the clinical data, right? Because there's other data elements that might have been part of that decision-making process. I'm curious to get your take on, do we expand? Does it mean? What does interop mean actually?
So, in terms of value-based care, I think it would be really helpful to be able to expand some of those, data elements that we collect, whether it's social determinants of health and, food insecurity or housing. And, we were chatting before about the elderly patient who doesn't show up. And is that because they don't have a ride,
transportation issues,
they have dementia, or, and I think it would be helpful to expand that as we, really try to give value-based care a go. And I think that would be information that would be helpful for both providers and payers to have available to them, because there are solutions.
Yes, there absolutely are.
And if you don't know where to apply, some of those solutions, it's like, okay, well, we need resources here because, we have a contract with Uber, but, we don't know to send them, and then it's it's hard.
And then it's unused capacity, people not getting the care they need, all that sort of stuff.
Exactly.
So I think, Kathleen, maybe like to put a bow on this like incredibly deep conversation on interop, maybe we'll close with one thought from you, which is, how do you define interop? What does that mean to you? And it's the most loaded question I've probably asked all day.
Oh man. So to me, as a attorney who focuses in this space, to me as a parent of a kid, or as a patient, or as someone who has friends who have providers, I mean, there are a lot of options there, Aditya.
All of the above. I just put a bow on it, which is, what is interop to Kathleen?
Okay. So I think of healthcare interoperability as, I'm a true believer. So it's really, from all of these perspectives, I think it's really important to be able to get the right data to the right people at the right time. Yeah. And that has always, since I got into this space in 2013-ish, that's been the sort of driving, right data, right person, right time. And there've been some really, really rigid rules that maybe have got in the way.
Sure.
And now that we are honing in on like a collective, like the industry has bought in, people have bought in, we're starting to see better APIs where, people are not guarding their, it's like more like stand the pie, right? I'm in stand.
Yes. All boats rise, right?
Yeah. Let's try to bring people in. Now I think maybe, and we'll see where we get, but maybe we can break down some of the rigidity and have it just work. Maybe it will work better because there's more buy-in. We had to have the rigidity before because there wasn't enough buy-in and people were just doing different things. But now, this is my hopeful. This is my hope.
It's your vision. It's your vision for interop. Yeah.
I think that if we can really have this holistic, and we still need rigidity or not rigidity, but we still need rules, right? And we need
a common framework on how to operate.
Exactly. And, whether that's TEFCA or something else, but having this, common way of thinking about it, and way, frankly, of, if someone's a bad actor, making sure that they have some repercussions.
Of course, in that too. Yeah.
Beyond just the naughty list, right?
Yes.
So I think, and we need to stop people, kind of, trying to say, this is my space, get out, like the protectionism. We gotta move beyond that too.
Yes.
So how's that for a loaded
that's an expansive answer on your vision of interop, but I think there's a nugget in there, which is just an incredible close. The right data to the right person at the right time. And I think that, like, as a vision for interop is a great North Star for all of us. So Kathleen, thank you so much for spending time with us today on Digital Health on Air. Excited to have you and looking forward to talking to you again soon.
Thanks, Aditya. This was great. I really enjoyed it.
Cheers.
Take care.